the first speaker today, still stands the gold standard for measuring intraocular pressure. However, intraocular pressure measurement is influenced by central corneal thickness, and a few conversion tables are available for influence the outcome of refractive surgery. Assessment of these corneal biomechanical properties have been difficult till now. How does the ocular response analyzer help us? It measures the biomechanical properties of the cornea and also gives the IOP. It utilizes a dynamic bidirectional applanation process with the help of an air pulse. It works just similar to the non-contact tonometer, except for the fact that the non-contact tonometer just flattens the cornea with the puff of air. Whereas with the ocular response analyzer, the cornea is further, it's not only flattened, but it is put into a state of concavity. And then it slowly gets back its original position. That is, it is flat, it reaches a stage of flattening again and then gets its convex position. Therefore, the dynamic nature of the measurement helps to get other important data. So how does it work? So there are we get two pressure waves. This is the pressure wave which is obtained when the cornea, so you get two pressure waves. The first pressure wave is the one when the cornea is flattened initially, and the second pressure wave is the one which we obtain when the cornea reaches a stage of the flattening after it rebounds from a concave state. And the difference between these two pressure waves gives us what is known as the corneal hysteresis. It is not only the difference between the pressure waves which we notice, but we should also notice what is known as the signature. That is, how the pressure waves, how is the peak, how is the amplitude. So we get two independent pressure values. This is due to the inward and outward applanation events. The two pressure values are not the same, and this is because of the dynamic nature of the air pulse and viscous damping of the cornea. The cornea represents an optimum viscoelastic system. That is, an elastic material, strain is directly proportional to the stress, independent of the length of time or rate of force applied. Whereas the viscous material, the resistance to the applied force depends on the speed at which the force is applied. So the cornea is a complex viscoelastic system, and it shows components of static resistance, which is elasticity, and components of viscous resistance, which is damping. And hysteresis is the property of physical systems that do not instantly follow the forces applied to them but react slowly. So the corneal hysteresis is obtained due to the dynamic nature of the air pulse, and it represents the energy loss when stress is removed from a viscous material. And what is the corneal resistance factor? It is a measure of the elastic property of the cornea. So we get certain parameters which are displayed when we do the measurement. The Goldman correlated intraocular pressure, which is the average of P1 and P2. The corneal hysteresis, which is the difference between P1 and P2. The corneal resistance factor, which is obtained by a formula which has been developed. The corneal compensated intraocular pressure, compensating for the central corneal thickness, and the morphological signal. Finally, we can also obtain the central corneal thickness utilizing a probe. So now we will be able to understand the signature much better. So there is the first pressure wave, which is an in signal peak. The second pressure wave, which is the peak of the out signal. The difference between the two gives us the corneal hysteresis. The average between the two gives us the Goldman correlated intraocular pressure. Now, how does this corneal hysteresis behave? There is no significant correlation with the corneal radius, astigmatism, visual acuity or axial length. There is a statistically weak correlation with central corneal thickness. Therefore, the corneal hysteresis is independent of the intraocular pressure in normal eyes. The corneal resistance factor is a measure of the cumulative effect of total corneal response to the air jet deforming the corneal surface. It is obtained from large-scale clinical data and proprietary algorithm. Corneal resistance factor is significantly correlated with central corneal thickness and the Goldman correlated intraocular pressure. Central corneal corneal thickness that is least affected by corneal properties is the corneal compensated intraocular pressure. This has again been developed using large-scale clinical data, and it is closer to the true pressure one can obtain. The signature of the ORA. So it is not only the values, all these values will be displayed. We usually take 4 signatures, that is the reading is taken 4 times. The best signals are taken. So what do we look in the signal? The amplitude, the regularity, that is there should not be too much of noise, and the distance between the 2 spikes. The height of the spike and the shape of the peak, whether it's sharp or plateau. The normal ORA parameters, the corneal hysteresis and central corneal resistance factor vary by about 2 millimeters of mercury in normal eyes. So clinical applications of ORA, it is helpful in identification of corneal diseases. It is very helpful in screening for patients for refractive surgery. It gets us not only IOP assessment but other parameters of the cornea. So let us see some ORA parameters in corneal conditions. For example, in conditions like keratoconus, Fuchs dystrophy, it is very useful. In keratoconus, if you see, the corneal thickness is reduced. If you see the curves, the corneal hysteresis is very low. The normal corneal hysteresis and corneal resistance factor is between 8 to 11. Here if you notice, the corneal hysteresis is 5, the corneal thickness is reduced, the corneal resistance factor is low. They are low amplitude peaks which have very sharp and thin peaks. Let us go to glaucoma. The central corneal thickness is an independent risk factor for glaucoma. Corneal resistance factor and corneal hysteresis aid in the diagnosis and treatment of glaucoma. The pathology in the lamina cribrosa is reflected in the detectable changes in the cornea. Corneal hysteresis is reduced in normal tension glaucoma and primary open-angle glaucoma. It's increased in ocular hypertension. I'll show you some waveforms. This is the waveform in early open-angle glaucoma where the corneal hysteresis is reduced. Corneal resistance factor is higher than corneal hysteresis. In progressive glaucoma, the corneal resistance factor increases because the cornea becomes very stiff. In end-stage glaucoma, all the values are reduced and there's a lot of noise. In ocular hypertension, intraocular pressure, Goldman is much higher than the corneal compensated pressure. Corneal hysteresis and corneal resistance factors are increased. The values are around 17. In normal tension glaucoma, the corneal hysteresis and corneal resistance factors are low, the value being below 8, and the corneal thickness is thin. What are the contraindications? We cannot use it in patients with penetrating trauma, corneal ulcer, post-keratoplasty. Limitations: able to measure IOP in nystagmus and in patients with poor fixation, and it makes a terrible noise which sometimes alarms the patient and they don't cooperate with the procedure. So what is the significance of ocular response analyzer? The invention and role of geometric parameters like central corneal thickness and topography represented the first paradigm shift in the management of glaucoma, whereas the invention and the role of biomechanical parameters like corneal hysteresis and corneal resistance factor will represent the second major paradigm shift in the diagnosis and management of not only glaucoma but also screening for procedures like refractive surgery. Thank you.
Thank you, Dr. Chokalingam.